What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist? That's not okay. Yeah, that's right. Tell me about it.
Yeah, no, so I was appointed as a market consultant at the end of 2018. And I was
What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information
Well, no, because I remember we've got
straight
photos in our little
from the
two-bedroom
specialist.
flat of having the consultant over, the registrar, when my dad was an SHO and they were all eating my mum's curry.
Yeah.
And but I don't think we do that nowadays.
It's harder in London, isn't it, I think, because everyone lives further away and consultants of today don't necessarily have big houses, like the way our parents' generation did. But I mean, I think there's still a place for it, and I certainly think back to when I was cared for like that and thought actually that was very inspirational and encouraging and just and so I always thought I'd try and do that for our trainees. And then the pandemic happened, and actually
So when did you become a consultant?
I started 2019,
Okay.
the middle of 2019.
Okay.
And I'd been thinking alongside that, wouldn't social media be another way of reaching a broader sphere and maybe presenting a newer, maybe different kind of, I guess presenting myself as someone that can be a consultant surgeon, but also, grounded and regular and not too hierarchical, and just generally just encourage people that they can do it, and it doesn't need to be this job that's high in the sky. And
The word that comes to me is soft, but I don't know whether that's a word you would like, or you think of yourself as being. But I appreciate softness in doctors.
Or certainly a more empathic kind of character, maybe.
Mm-mm.
And I sort of think if I can do that in my role as someone that's hopefully now well known in my specialty, then it gives license for other people to not be too, toxic. That was always my initial thought.
And so that's why you started the Instagram.
Yeah. So I post stuff about work, but I also post stuff about home and being a dad and
so showing balance,
enjoying music and stuff, stuff at life outside medicine. So value for that. And then it's turned into more than that. It then opened up teaching opportunities, and it's. I suppose it has probably turned into a opportunity to give good information out there for patients and other doctors. ENT is not something you get covered very much at med school, so the stuff I'm putting out there for patients is also useful for doctors, and so maybe it has also ended up turning into an adjunct to my practice in terms of people finding me, but and I see that as a bonus, but I've not spent any money on it, despite apart from buying a nice microphone and treating myself to an iPhone. But it's we had an Australian surgeon come visit this week, and he said all the trainees in Australia follow you, and we read your books and stuff. So I thought, well, it's even for that, it's the reach of it is worth it. So.
Wait, so you've written books too? So is this where your introduction starts then? Because I have hit record.
I know, I haven't even told you my name yet, but I'm about to do my fourth book. They're all geared towards ENT trainees, and I think most ENT trainees in the UK would maybe say that they use my books to get through the exams.
Okay, so educational resources.
Yeah.
Got
So at least 3 of them are exam-based books. One for the MRCS, and then 2 for the FRCS, and then another one about imaging and stuff like that. So,
okay, brilliant.
Yeah.
Would you like to give us a quick introduction?
Yeah. So I'm Joe Manjaly. I'm a consultant ENT surgeon, specialising specifically in ears and hearing issues, hearing restoration, hearing implantation for adults and kids. And I'm based at the Royal National ENT Hospital, which is part of UCLH, so University College London.
Yeah,
Hospital.
that's where I did my training.
Right, yeah, so
it's
you feel fondly towards
Yeah, it was a
UCL.
lovely little rotation, but you're right, I think it was a few weeks of that.
Yeah, you don't get very much, yeah. And so we don't have a big window to inspire people in ENT, and so most people that go into it end up discovering it a bit late, but it is a bit of a hidden gem of a specialty. And I love the job. I mean, despite all the difficulties you hear about working in the NHS, actually we're maybe a little protected niche corner where we get to do good work, and obviously it's an amazing location being in central London. It comes with a great platform, and I also do private practice down the road at largely based at 1 Welbeck, which is just near Oxford Street.
Okay, great. So you're familiar with the format of the podcast. We have around 25 minutes to cover 3 questions.
Yeah.
Shall we go straight into it?
Yeah, you can ask me whatever you
Okay,
like. Yeah.
brilliant. You'll regret saying that because I'm the most annoying student. And I'll say, but why does the hair move that way? So the first question is, what would you like to share with the general population about ENT, or specifically hearing, because that's your subspecialty?
Yeah. Well, there's so much to share, but I suppose you did ask me to think about, perhaps different myths that exist in our specialty. The first one that came to mind is about wax, because wax has kind of been, or earwax has been sort of turned into this hygiene issue that it should never have been turned into. And people, I get a lot of people that come saying, I'm producing a lot of wax, or how do I clean my ears? And actually...
So they present to you?
Yeah.
So even get as far as the ENT surgeon to present, so it's not just a GP issue.
Yeah. And also in general life, you get asked that question a lot. How do I, if we're telling people not to clean their own ears, then how do you keep your ears clean?
Right.
But actually the message is the whole keeping your ears clean shouldn't really be a thing, because cleanliness and wax the wax is not about cleanliness. Your ears should produce wax, and every time you open and close your mouth, your ear should self-migrate wax from inside to out. And so it's quite normal to find wax coming out of your ears, and it's not a hygiene issue, and it's your ear's way of staying free of infection, keeping out insects and things like that. So wax is normal. Now, yes, there will be the type and volume of wax you produce is in part genetic, and so there will be people for whom their anatomy means their self-cleaning mechanism is not as good as it could be. And so there are some cases where wax should be removed. Okay, basically 3 scenarios. 1 is it's causing pain and blockage. 2, it's causing hearing loss. Or 3, a specialist needs to remove it to see what's behind. But everything else, it can be left. And actually, your ears can accommodate a load of wax before it starts to impact your hearing. But of course, social media videos of wax removal, tend to be very addictive, and people love.
Never seen one.
Yeah, I mean, if you look on YouTube, they get thousands and thousands of views, and there's a whole industry around wax removal. And fine, if you want to have your ears cleaned with wax, fine, then go and get it done by someone with proper equipment, proper training. It shouldn't be done by the receptionist in your local eye care shop. It should be done by someone that's properly trained. Ideally, an ENT specialist or an audiologist. Now, I'm also realistic to know that workforce capacity means that probably not everyone that needs microsuction will have it done by an ENT surgeon. But at the same time, I can't stress the fact that it's a delicate structure. If it's done by the eardrum and the middle ear structures behind, if it's not done by someone that knows what they're doing and knows what they're looking at, it's precarious. It's very much a medical procedure, and I think there are movements to kind of bring it into the realm of wellness and aesthetic beauty, like going for a haircut, but it shouldn't be ever seen like that.
So that's different ear suctioning to ear syringing. Is ear syringing an out of date?
Yeah. So syringing probably still exists purely for logistics, right? So the safest way to have your wax removed is with someone using a microscope or an endoscope and a suction. And syringing is more of a blind technique where you flush the ear canal with saline or water and the wax will come out. But the latter you don't need a microscope for. So if everyone was to have microsuction, it means we need to put loads more microscopes and trained people and suction tanks in more and more places. And until that is viable, syringing will still exist in GP surgeries. But ideally it's...
But really you should be accessing that just to remind myself if there's pain or hearing loss.
Yeah, exactly.
Is that correct?
Exactly. So syringing... it can. So syringing can, in some cases, will be fine, but it also is problematic in the sense that if someone hasn't actually looked in your ear and confirmed that there's no pathology there, then actually just flushing fluid into your ear is not ideal.
Well, I wouldn't want it.
No.
So, what are the altered mechanisms? You were saying that sometimes it doesn't clean, or what's gone wrong?
Yeah. So your usually your outer 2/3 of your ear canal will move wax naturally from inside to out. The inner third won't, and so if for any reason when you use cotton buds, for example, and this is why we say don't use cotton buds, is you will get some out and it'll feel very satisfying, but you will also inevitably push a little bit in, and once it's pushed onto the eardrum, it won't self-clear, because you're every time you open and close your mouth, your jaw is interfacing with your ear canal and moving changing the shape of the ear canal, and that's how wax migrates.
Okay.
But once it gets to the inner third, it will just sit there and stay and accumulate.
Get it.
And so that's why cotton bud use is not a good thing.
Okay.
So
how long is the ear canal? Not that I'm calculating how far to go.
It's about
when I get
about
home.
2.5 centimetres.
Okay, 2.5 centimetres.
Yeah,
That's the entire length, and it's only the outer 2/3 that's self-clean. So you don't want to be pushing anything in.
Exactly.
Okay,
Exactly.
Okay, cool.
I can usually tell when someone used cotton buds, and it's not like I tell anyone off, but you can, if wax has reached down the bottom end, it's been pushed there somehow.
Yeah, so. And then just cleaning the outside ear?
Yeah, so that's okay. With however you want to clean the outside of the skin is fine.
So once the wax has come out, so it's visible, that's
exactly.
Easy enough to do with a cotton bud. You're okay with that?
Yeah, or you can just use a
towel.
A wet swab or wet flannel or whatever.
Okay.
Yeah.
Okay, cool.
Yeah.
Okay, cool. Is that it for the GP one? Not saying that that's not significant.
Oh, fine. Well, I think that was the general population.
Sorry, that was the
one,
general
wasn't
population one.
Yeah, I think so. I mean, what I'll share about advice for other doctors probably is equally of relevance to the general population. But
the way that it's structured is that you can continue to listen.
Yeah.
So if you feel as if, oh no, that's really easy stuff, and I want to listen to the postgraduate level, you can.
Yeah.
And then you can tune out whenever
Cool.
is appropriate.
Yeah.
So the next level question, if you're okay,
Yeah.
moving on, is what do you want to share with your GP colleagues?
Yeah. Okay. A couple of things, but the thing that comes to mind most is sudden hearing loss is an emergency, right? And by extension, if someone presents with tinnitus, for example, or tinnitus meaning they're hearing a new sound that they shouldn't be hearing, what you really don't want to miss in that situation is a sudden sensory neural hearing loss. Okay, and this has become very pertinent and evident in recent times as we've moved towards a sort of more telemedicine culture. in that someone presenting to primary care saying their ear is blocked or they've lost some hearing, them being assumed that it's probably a cold and they've got a middle ear effusion causing it and being given decongestants, when actually they had a sudden sensory neural loss that should have necessitated early steroids. Okay, so broadly, just to sort of break that down, your ears deliver sound to your brain, and the anatomy of your ear can be broken up into the conduction system and the microphonic system, if you like. So the conduction system consists of your pinna, your ear canal, your eardrum, and the three ossicles, the three bones behind your eardrum. But that conduction system maximises the amount of ambient sound that's reaching the inner ear, i.e. the microphonic system. And I call it the microphonic system. Essentially what it means is you've got a series of structures that convert mechanical energy into electrical signals. And going into more detail on that, your cochlea contains fluid bathing thousands of hair cells that move with those sound vibrations and open ion channels and generate current to the brain via the vestibular cochlear nerve. Okay, so again, just to go over it, you've got a conduction system and a microphonic system. And what's important is differentiating any hearing loss as either a conductive loss, which having a cold and having middle ear fluid will cause a conductive loss, versus a sensory neural loss, i.e. the cochlea has suffered some kind of insult, whether it be viral or autoimmune or microvascular, but an inner ear insult, i.e. those hair cells have become insulted. We know that the earlier you start steroids for that latter group, the greater your chance of rescuing the hearing from becoming permanent. And there's good evidence out there that steroids reduce your chance of hearing loss becoming permanent. And I think because...
Sorry, what is the cause of that though?
Well, we often don't find out. So that patient will typically go on to have an MRI scan to rule out benign growths on the hearing and balance nerve. You might have heard of schwannomas and meningiomas, but actually the vast majority, we don't prove the cause. We end up assuming that it was either a viral insult or a microvascular insult or an autoimmune insult. But you need an electron microscope looking at the cochlea to be able to actually see what's going on in there. So in the absence of being able to prove a cause, we group it as, we term that diagnosis sudden sensory neural hearing loss. And it's easy to miss because there are no other visible signs. So, and in an era of remote consultation, it's even more important not to miss it. So if someone presents with an acute hearing loss, actually what they need is an examination, and if you don't have access to audiometry, a tuning fork test. So if you do a Weber tuning fork test, you place the tuning fork on the forehead. If it's a conductive loss, the sound will be heard louder in the affected ear. Whereas if the sound lateralizes to the unaffected ear,
is heard more in the unaffected ear.
Correct. Then that should ring alarm bells that this is a sensory neural loss. They need urgent steroids. They need same-day referral to urgent ENT for a proper audiogram, and eventually potentially intratympanic steroid injections.
Oh, okay.
So that's the sort of, those are the treatment options available. Okay.
And so for the patient, how do they usually present? It's just hearing loss. They have no other symptoms.
Yeah, so
no balance problems.
They might do. So it sometimes it can just happen as an isolated hearing loss.
And wake up or?
Yeah, just out of the blue, just no trigger. Obviously, if they've had a head injury or some other explanation, there's that group as well. But
that was my next question, coming from sports and exercise.
Yeah. So we can get onto that. But sudden hearing loss with no trigger can happen to fit and well young people out of the blue, and anecdotally seem to see it happening during periods of physical and emotional stress, but not always. So that sometimes there can be no other clues.
Okay. Now, with or without any of the balance issues, that is not.
Yeah. So it might be isolated, but it can also come on with tinnitus and or vertigo. So sudden onset rotatory sensation, which feels quite disabling and usually with nausea and vomiting. In the latter, we sort of term that labyrinthitis. So labyrinthitis, someone experiences labyrinthitis, that is essentially sudden onset vertigo with nausea and vomiting and a sensorineural hearing loss. People get dizziness without the hearing loss, and we term that vestibular neuronitis. But yeah, essentially, you don't want to miss the sensorineural hearing loss, because
and labyrinthitis, sorry, just
yeah. So
you treat that with steroids as well.
Yeah. So if a labyrinthitis features a sensorineural hearing loss, then the same rules apply. You've got that early time window for steroids. Mm-hmm. We just completed, my colleagues have led it actually, a national observational study looking at sensorineural hearing loss across the country, and there's good evidence to show that the earlier you administer steroids, the higher the chance of complete recovery.
Okay.
Yeah.
And we're talking about hours, days, or weeks?
Well, next working day, ideally.
Next working day.
I mean, the ones I've seen recently that have...
And when's too late?
Well, that's open to debate. But I think if someone came to see me, 3 months after the event, that's when I would start thinking about saying, well, we've got marginal gains for going down the steroid route.
Yeah, so if I'm just thinking for your telehealth consultation, you've got enough time to call them for a face-to-face next day.
Yeah. And if they're really stranded and you can't see them, you can ask the patient to hum, and if they hear the hum in the opposite ear, that's kind of like a alternative way to.
Okay, great. So there is a way of telehealth. Okay, excellent.
Yeah. So that's sudden hearing loss.
Thank you.
Yeah.
Very useful.
There's a national randomised control trial happening at the moment called the Starfish trial, which is now comparing oral steroids versus intratympanic steroids in the treatment of sudden sensorineural hearing loss. And at the end of that trial, we should know which is better.
Okay.
At the moment, most people will start with oral steroids and then go to injections. Mm-hmm. So.
Can you tell me the doses, just out of curiosity?
Yeah. So oral prednisolone usually 1 milligram per kilogram once a day. So 60 milligrams typically.
How long for?
Usually for a week. And then you'd test the hearing at that point. Mm-hmm. And then if there was incomplete recovery, then there would be a discussion about steroid injections through the eardrum. Mm-hmm. The idea being that you inject dexamethasone or methylprednisolone through the tympanic membrane with the aim that it will sit in the middle ear and some of it will diffuse through the round window membrane into the cochlea, where the problem is. Mm-hmm. We can't inject the cochlea directly without killing the hearing.
Right.
So.
Okay. And how much do you inject then?
Well, you try and fill the middle ear. So usually you get kind of 1 to 2 millilitres in.
Okay. Is that uncomfortable?
Well, the discomfort is, if you, obviously in an otologist's hands, you can keep your hand steady and that's fine. You numb the ear, obviously, as well. The discomfort is more to do with the makeup of the fluid. So methylprednisolone really hurts. It's more to do with the actual pH and makeup of the drug.
Oh, interesting.
Yeah. With dexamethasone is less painful.
Okay, and you can use either or.
Yeah, there's some evidence that exists out there that methylpred has a slightly higher inner ear absorption, and some people will use it for that reason. Mm-hmm. But it really canes. Actually.
I was even thinking just about that fullness.
Yeah. That usually settles by the next day
because it's absorbing.
Yeah, it will usually drain down the eustachian tube.
Okay.
Yeah.
Okay. Brilliant. Thank you.
Is this all kind of making sense?
Oh, this is yeah. Why do I not look as intelligent as I am?
We're such a niche part of this.
Do you know what it is? I think it's just interesting because when you're trying to explain the next steps to the patient, you can be stumped. They're like, so what are they going to do? If you vaguely kind of know, okay, well these are the options, but then hear it from the specialist, it just facilitates that patient pathway.
Yeah, and engenders more confidence in the...
Yeah. So it's not that I agree.
Excuse me.
Bless you. It's not that the GP needs to know the dose per se, if this is a GP level question. But I think, they can think of, those 3 patients in my career and just knowing then what goes on, I think just helps as well deposit and help this conversation stay in their mind, so they can recall it at a later stage as well.
Kind of related to this, you asked me before we met up about tinnitus, right? So what I find with tinnitus is that a lot of people kind of either get told by their doctor that nothing can be done and just live with it, or they go online and read this message that basically it's incurable and you're going to live with it forever, and they then go into a bit of an anxiety spiral. And actually none of that is true, and it is very manageable. And also it's not just a case of you have to live with it. The first thing is to basically make sure there's no concurrent hearing loss, because that then all the rules about hearing loss management apply.
And that you send to an audiologist?
Yeah, well, so if there's a sudden sensorineural loss, then you go down the ENT pathway. If there's any concurrent neurology, then you'd think, has there been a stroke or a carotid dissection, and go down that pathway. Okay, and so that, if someone's got sudden onset pulsatile tinnitus in one ear.
What do you mean by pulsatile?
So they'll report hearing a whooshing in time with their heartbeat. So if that's kind of sudden onset whooshing sensation in one ear, that should ring alarm bells for a more urgent referral. So again, another group of patients that don't fall into the category of tinnitus is tinnitus and just live with it.
Sorry, urgent referral to where? So if you're worried about a carotid dissection,
then A&E, stroke team.
Okay.
I've picked up at least one of those in the last year. Chap presented with.
And their only presenting complaint is a
sudden onset pulsatile tinnitus.
Unilateral.
Yeah. Now it might be that a lot of those cases end up being nothing, but again, you don't. Those are the things you don't want to miss. So you don't want to miss.
Well, it's definitely worth doing a neurological examination for.
Yeah, and it might be obvious that there are other neurological signs, but yeah, I think basically any sudden concurrent sensorineural hearing loss, go down the urgent ENT pathway. Any neurology, think about stroke team, and then then you also want to not ignore patients with unilateral symptoms. So they still deserve an ENT referral. So any unilateral symptoms.
Are we still talking about tinnitus now?
Yeah. So if you've got one-sided tinnitus.
Do you ever get... Sorry.
No.
I'm going to ask a dumb question, but on purpose for my audience. So I always thought tinnitus was unilateral, but you can have bilateral tinnitus.
Yeah, bilateral tinnitus is more common. So now breaking it down, tinnitus, the approach to tinnitus in general terms is tinnitus will either be objective or subjective. Objective meaning something in your anatomy is causing that sound. So let's go back a step further. Tinnitus means you're hearing a sound that you shouldn't be hearing, right? So it's not a diagnosis, it's a symptom. Tinnitus means you're hearing a sound that you shouldn't be hearing. It's either objective or subjective. Objective meaning something in your anatomy is causing that sound, or subjective, actually your anatomy is healthy, but the way your brain is processing sound is not doing a good enough job, and you're aware of a sound that you shouldn't be hearing. Objective counts for about 10%, subjective counts for about 90%. And so the approach in the consultation room is to basically first rule out an objective cause. And you do that through the history, examination, audiometry and tympanometry, and sometimes scanning. And that will help you to discover that 10% objective causes and treat it.
A mass?
So it can be as simple as a middle ear effusion, infection, and then more rare things like schwannomas, paragangliomas, so middle ear vascular tumours and things like that. So those can all cause tinnitus.
And that, if we're talking about a ganglioma or schwannoma, that's a unilateral tinnitus.
Yeah, because apart from rare genetic conditions, you're unlikely to get bilateral schwannomas, and there's another rabbit hole to talk about. NF2, you can get bilateral schwannomas, but ordinarily, if there's a tumour causing this, it would usually be unilateral.
Okay, and then the other 90%?
Yeah, so then, with that group, you don't want to dismiss them. So actually educating the patient as to how auditory processing works is really helpful.
Is this when you've listened to music too loud? Is that group?
Okay, so hearing loss and tinnitus are inherently linked, right?
Okay.
So if you have an unmanaged hearing loss, you will have increased effort of listening every day. Your auditory processing will kind of be exhausted, and you'll be more prone to tinnitus. Now, loud noise exposure can cause sensorineural hearing loss, and so by definition, loud noise exposure causing hearing loss can be associated with tinnitus.
Mm-hmm.
So in that sense, yes.
Okay.
But subjective tinnitus isn't always related to loud noise.
Mm-hmm.
It can be because of something as simple as being stressed, tired, poorly slept, ill from some other reason.
Okay.
Anything that basically affects your daily cognitive health, your daily energy levels, can predispose you to tinnitus.
And that's momentary or temporary tinnitus? So it can come and go.
Either. Like momentary tinnitus, is very common. Most people in the general population will get that, you suddenly get that ringing and then
so we don't need to worry I have a swallow.
No, exactly. So yeah, and people do end up worrying about that, going and Googling, and so yeah, momentary tinnitus shouldn't be a worry unless you notice a hearing loss that persists. But yeah.
And the reason why I asked you about tinnitus was then Parkinson's. Well, then what kind of tinnitus does that present as?
Yeah, so I wouldn't say we kind of have a specific Parkinson's group of patients that suffer from tinnitus, but what I would say is that anything that can affect your neurological health, by definition, can lead to tinnitus.
Okay.
Because anything that affects your central auditory processing can mean that you start perceiving sounds that actually are not being delivered to your brain.
Okay, so that's a subjective.
Yeah.
Okay, great. Thank you.
Cool.
And then finally, what would you want to share with your specialist colleagues, other specialist consultants, or a one-to-watch area of research?
Yeah,
something
okay.
that you're fascinated by?
So I guess as an otologist and a hearing implant surgeon in a tertiary unit, I'm at the coalface of all the new technological changes that are happening year on year. And those things actually take quite a while to filter through to the general specialism, including your general ENT surgeon in a DGH, for example.
DGH is District General Hospital.
Yeah,
so you're a super specialist unit, is what you're saying.
Yeah, I have the luxury of not having to worry about
Yeah.
nose or throat. So this is not criticism. This is just I'm just fortunate to be in that sort of niche area.
Yeah.
But with advancements has come a shift in philosophy.
Mm-hmm.
So 20 years ago, or even 15 years ago, when I wrote my first book, I was editing the first edition a few years ago, and in it we've written single-sided deafness in children should be managed conservatively. And actually, we realise more than ever now that even a hearing loss in one ear has a significant impact on someone's quality of life, adult or child. It affects your ability to localise a sound. It affects your ability to hear in noise compared to quiet. It affects your daily listening effort and therefore mental fatigue. And it will also have impacts on, your appreciation of stereo music and all that sort of thing.
Yeah, and the way the brain develops depending on the age of the child.
Yeah. So your auditory pathway, if it's not used, will kind of it will shut off and be used for other things. So now in a quiet consultation room, a doctor is not going to appreciate the challenge that unilateral hearing loss brings. And actually, if you're not asking the question of the patient, actually, is this really tough for you in a noisy environment? Or asking parents, is it really hard? Are they more inattentive in a noisy classroom compared to at home? Do you find yourself avoiding social situations because you don't know where the person's talking to you from? Those situation-specific questions shed a lot more light on how difficult unilateral hearing loss can be. Okay, so I guess unilateral hearing loss needs more, it deserves more respect in the sense that we should be more willing to offer intervention rather than tell people to manage it conservatively. in the same way that, I shouldn't. It's not really acceptable for me to say just use one eye, when we could offer options to get your other eye working.
Mm-hmm.
The reasons that philosophy has existed really are around the limited options for hearing rehabilitation, right? So, as an otologist with an ear that's not hearing well, the first question is, can I do middle ear surgery to get the hearing better? Okay, that will involve some risk, and the more you're doing that kind of surgery, the better the risk benefit decision is. Okay, so that's the first thing. Then, beyond that, the question is, can this patient benefit from a hearing aid, which they may or may not get along with or be able to benefit from? Beyond that, the question is of, could they have a hearing implant? And the array of hearing implants is very different now in 2024 than it was 20 years ago or even 10 years ago. So we could go into more detail on this. My Instagram channel has much more content on this, but we, the options now are very different than they were. So the options available 15 years ago were potentially much more unpalatable for your average patient, and that maybe steered the specialty towards a culture of, well, we'll only refer the patients that are really, really struggling and really asking for help. Whereas actually, all patients with single-sided hearing loss should be offered all these options now.
So where would you send your specialist colleagues to read up more on this?
The take home is anyone that's struggling to benefit from a hearing aid can be referred to an implant centre. So there are 4 in London, for example. There's us, UCLH, Great Ormond Street, Guy's and St Thomas's and St George's all do cochlear implants. And then there are some other units that do bone conduction and middle ear implants as well. But you don't need to remember the audiometric criteria. It's just basically, if they're struggling with a hearing aid, don't let them struggle on, refer them for hearing implant assessment.
Okay, great. And throughout the country? Yeah.
So every region will have a centre that does this sort of thing. But you're more like, most of our work still comes from our own referrals rather than, so there's obviously loads of people out there in other.
So sorry, I've missed something. How many specialist centres? There were 4 in London.
Oh yeah, so in terms of cochlear implants,
mm-hmm.
there are about 20 centres in the UK.
Okay.
There are 4 in London.
Okay.
When it comes to other types of hearing implant,
mm-hmm.
there will be units that do those that don't do cochlear implants, and so there are more of those.
Okay.
I don't have an exact number.
Fine.
But in every region,
either or. One's not superior to the other. It's just restoring some sort of hearing.
Yeah. So someone might be suitable for one or the other or both.
Oh right, sorry.
So but the key thing is, if they're not able to benefit from a hearing aid, make sure you offer them the option of a referral.
And so there's a cultural change that you want to facilitate.
Yeah.
Okay, good.
Yeah, definitely.
Okay, lovely.
And the other thing, sort of slightly related to that, is if a patient has an air bone gap on their audiogram, so they've got
mm-hmm.
a conductive component to their hearing loss, then an otologist that patient should have the opportunity to have an otologist comment on whether that air bone gap can be closed.
Mm-hmm.
And it's fair enough to refer on if you yourself, don't do that kind of surgery. Mm-hmm. And so, rather than just give them a hearing aid and not give them the options, I really think all patients should be given all options, right? And so conductive hearing loss, there should always be a question asked of, can we do middle ear surgery to ameliorate it? So those would be my messages to colleagues.
Brilliant, thank you. Thank you very much for coming as well.
Cool, thanks very much. No, thanks for inviting me.
Pleasure.